guests. We welcome you to the digital workflow for definitive prosthesis, and this lecture will be presented by Jeff Carlson, CDT. My name is Nicole Smith-Scudder, and I am happy to be the host and introduce our speaker for the evening, Jeff Carlson, CDT. Jeff Carlson has more than 40 years of dental experience with almost 30 years focused on dental implants. Jeff is the primary author of a 300-page fully illustrated cookbook created for restorative dentists, and he is the co-author of a corresponding auxiliary manual. Jeff co-developed a restorative-based training program that more than 9,000 dental professionals have attended nationally and internationally. As a senior implant specialist for NDX, Jeff provides technical chairside support and lecture across the country on immediate loading full arch restorations and sequence guided prosthetics and the latest advancements in implant technology. So I welcome Jeff. The floor is all yours.
Why, thank you very much, Nicole, and hello, everybody. So, what I would like to do is really focus on some of the nuances with the digital workflow. And as you know, our topic is about the definitive prosthesis protocol. It is so amazing how this has changed in the past, even the past year, but for sure the last couple of years. Most doctors were hearing, I want to do, I want to be everything digital. I don't want to do anything analog. Um, it's pretty close to being there. There's still some things that we need some analog information or might need to go analog. So let's jump right into this. I do have to say, as a disclosure, that I am a full-time employee of National Dentex, so I'm compensated by National Dentex. The Also any commercial support is taken care of by National Dentex. The other thing that we are doing now is we're needing to just quickly state our learning objectives. So my goal for you all is to have an understanding of the scanning, all the scanning components and devices that will be needed and that are available. And then really how to send all these records to your laboratory, a lot about communication with your lab, and really how, some of the overcoming the challenges that can be associated with when you're trying to do a digital workflow going from a provisional to a final. So I'm hoping to answer a lot of questions for you all tonight. Again, we will have a Q&A at the end, so stay tuned with us for that. You're going to see that also to be compliant, that this is an educational activity provided without commercial bias or product endorsement. Product names and systems are in reference for educational purposes only. Want to be totally compliant here. All right, so pull the curtains back and let's get going on restorative, which we refer to as phase two, which is the definitive, working towards the definitive prosthesis. And again, we're going to be focusing on the digital workflow for that. So I want to address something that I think there's still a lot of confusion about is photogrammetry. And where does photogrammetry play a role when we get into the definitive prosthesis? It's not mandatory to have this by any means. I mean, you don't need it for even phase one for the surgery. So you can do full arch digital workflow without it. Those of you that are, I just want to share with you that if you're working with another clinician who has grammetry, sorry, that where they can utilize this and how the benefit of that technology would be. So knowing that you're going to have of course, the scanning units, and then the scanning indicators, scan bodies, different names for different systems, that's going to provide you a very near perfect 3D registration of the implant / MUA, because you're recording it with the MUA abutment, multi-unit abutment on top of the implant already when you're attaching these scan jigs, scan bodies to the MUA for your scanning protocol. So it's going to give you a near perfect relationship of each of the implant abutments and abutments to each other in the arch. However, and then when you're getting to this phase of the for a final, that what you're going to use this for is to validate the positions at post integration. And this is really, for those of you that have it, be sure and use this technology at this stage, especially when you've had, maybe there's some bone grafting that was done. Sometimes, many of you that have been doing these cases, you know that we don't always, might be an implant that we're not able to load immediately. So we leave it off the provisional and come back and pick it up at this stage. I'm not going to get into all that detail. But that's what your laboratory, you have any questions, reach out to your laboratory and they can walk you through some of that. So the photogrammetry is going to be able to validate at the point of post integration, the near perfect position. And I think the numbers are usually around 10 microns is what they're talking about as far as accuracy. So, but we still need to keep in mind, this is something I think a lot of people miss, especially if you're in a scenario of the restorative doctor where you've referred your patient to a specialist for the implant surgery. Sometimes the time of surgery, when the clinician places the implants, places the multi-unit abutments, maybe at the time of implant placement, didn't get the best stability, initial stability. They didn't maybe get their 30, 35 newtons of insertion torque, yet you're still comfortable with maybe loading an implant at maybe even 15 or 20 newtons of insertion torque because it's in between other implants. Maybe you have 6 implants in an arch. My point being that maybe the multi-unit abutment wasn't tightened to the manufacturer's recommended torque values. So that should be noted by the surgeon. And if you're doing the surgery yourself, you want to always make sure and note that in the patient's chart. In other words, if you placed an implant in a maxillary soft bone, say D4 bone, and you got 30 newtons, maybe 20 newtons of insertion torque, and the multi-unit abutment manufacturer's final torque recommendation might be 30 newtons of insertion torque. Well, maybe you're not going to load it all to that because it's going to spin the implant, especially if it's an angled multi-unit abutment. You could really interfere with your proper path of insertions and et cetera. So my point is that this is the time to go back before you do any scanning, even if before you do your iOS scanning, if those MUAs were not to their final torque, to torque them again now. Or when in doubt, then you'd want to go ahead and torque them now to that maximum torque. So that's something I think people get missed. And the other thing that sometimes can happen is that it's not seen at the time of surgery, is that the bone profiling may have been needed. It may have been performed. However, there still may have been a little ledge of bone that might prevent the MUA from seating completely flush to the platform of the implant. And it may not be picked up on a scan, especially if you're just doing a panel, post-op panel to see if everything is seated. And now that bone dishisses over time. Now you have a little gap. So it's very important to make sure that if you're the restorative doctor, you didn't do the surgery, communicate with your specialist ahead of time to make sure whether or not the multi-unit abutments have been torqued to their final insertion torque. So again, those of you that might be new to understanding about what does photogrammetry look like, the scanning units, these are some of the common ones. I mean, there are other ones out there. Just because I'm not showing them doesn't mean that we don't work with them or we don't recommend them. But these are some of the more common ones that we are seeing coming into our laboratories. Um, the did you know? So since photogrammetry does not capture the required data of the working arch dentition and the tissue of the working arch, or the opposing dentition, or the bite, even if you're doing the photogrammetry at this stage, verifying the position of the implants and multi-unit abutments to each other, you still have to come in with an intraoral scanner and get this other required data. So you're always going to have to do, for going from your provisional to the final, you're always going to have to do your iOS scanning. So we're seeing the term that we're trying to use when we talk about um, iOS scanning for full arch is precision iOS scanning. And I kind of feel like I kind of coined that phrase. Maybe it's been out there, but I use that in my presentations because I think what you'll find is the scan bodies that are utilized for your crown and bridge cases, your 1, 2, 3 unit bridges, things like that, um, that those scan bodies do not have enough geometry on them when we're doing for your full arch scanning. So you do have to have purchase some type of a precision iOS scanning system. And I'm going to show you a few of those here in this presentation. Um, so you're always going to have a precision scanning system. So if you don't have that, you need to be, talk to your, laboratory representative, and they can help you figure that out. You're going to see in some of the presentations you'll see online that I have, or maybe some other presentations I may do, or for some other people. NDX has coined the phrase simply iOS and trademarked that phrase simply iOS, meaning precision iOS. It's the same thing. So it's NDX's terminology for precision scanning. But for our educational presentations, we're trying to keep everything very generic. So I just wanted to make this statement about it. So if you're looking online at some of our other non-CE programs, you may see that terminology. It's the same. I don't want you to get confused about that. Um, Lastly, um, NDX, we do strongly recommend that from provisional to not go right to the final, that you do a resin prototype try-in before, again, going to your definitive prosthesis or your final restoration. However, it is doctors, you're in charge here. It's your choice. You could, if you're happy with the provisional, the patient's happy with phonetics, aesthetics, tissue adaptation looks good, bites good, and you're ready to go to final, you can do that. So your second appointment after this first appointment of the records, your second appointment could be deliver a final. But again, we do strongly suggest that I'm going to show that in my presentation doing the resin prototype try-in. I really recommend with this technology, full arch technology, you've got to have a lot of preliminary conversations with your laboratory ahead of time. Don't wait till patients in the chair or they're coming in tomorrow and start asking the lab some questions. In other words, talk to your lab ahead of time because there's going to be, on the first restorative appointment, there'll be some scans that some labs don't request that you submit or provide a certain scan. I'm going to show you the ideal way to help ensure that you get optimum results. It's not saying if you're not doing everything that I'm showing you this evening, if your lab is doing something different, that they're not doing it right. Just as long as you're working with a lab that does this routinely and not experimenting with you, you're gonna be fine. But the key is just work with the laboratory, know what their protocols, their requirements are, and you're gonna be just fine. The great news about digital technology, digital workflow, is we don't have to deal with all this. And those of you that hopefully some of you are like nodding head, taking your wine, toasting it, right? That nope, no more of this. Uh, of all the analog, the multiple appointments and things like that. So that's kind of the nice thing, nice for the patients as well. Um, so let's look at our first appointment. So where patients is post-integration, we're 4, 5, 6 months out from the day of surgery. You're ready to move on with the final. We're going to talk about what we're going to do, or we're going to ask of you and protocol for you for a resin prototype try-in. So this is your first appointment. We do want to have take new photos. We like to see these. There's about 4 to 5 images we like to see. We want to see the full smile. We want to see kind of the left to right profile retracted. Really nice to see those retracted images. It gives the lab just more visual reference of how things are lining up, buckle over jet, things like that. We get to see what the patient's used to in all those different areas, and more photos, the better. So if you have additional photos you'd like to take, please do that. We love to get more photos. Now, I'm going to show you that there's most of our laboratories, we're all asking for are 6 scans, iOS scans at this first restorative appointment. So I'm going to take them one by one. So the first scan that we're going to be looking for, so again, the patient arrives. You have a conversation with them, obviously, about what do you like, what do you don't like, is there anything you'd like to change? Go again through their F and S, phonetics, their F sounds, their S sounds, making sure everyone's happy with that. So, and regardless if you're going to change things or not, you still need to do this. You want to scan the existing provisional in the mouth. So the first thing is, after your conversation, is to go ahead and do a 360 scan. And importantly, you want to capture about 5 millimeters, a minimum of 5 millimeters of the alveolar tissue uh, below, that transition line is very, very important. We're fine tuning this now, so we need to see that transition line. We need to see how the tissue, the bones remodeled, the tissue is remodeled and healed. We need to see that because in the final, we're going to make everything. When I say tight, um, we still want to make it cleansable for the patient, but we want to make things where it's not the patient isn't having big gaps or being compressed. They can't get their water pick's not functioning well to get underneath it. So we want to see that transition line. A very important image to capture in your scan is this. The more, the better. Get as much of the tissue area as you can. That's your first scan. And the second scan would be to scan the opposing. And even if you have scans from before, you always need to take a new opposing scan because something may have changed over those few months. Usually if you think about it, if they've had one arch done with this, they probably have some challenges with the other arch. Maybe they couldn't afford to do a double arch all at once, so they're splitting it up, maybe doing one this year, one next year, etc. But either way, always take a new scan of the opposing. Very important to do. Now, I did put this scan in because for the opposing arch, this is acceptable. I mean, we're looking for the occlusion off of that is really what we're looking for, and the buccal overjet. I would like to have seen, still would like to see more tissue captured in this, but I did want to throw this up because it's not uncommon. Our labs, we get these images. Just know this, the better your scans are, the better the laboratory can do. So if you think that we're being greedy or being picky, it's because we want to give you the best prosthesis for your patient. That's what it's all about. Then the third scan would be to scan the bite. Uh, People usually just scan one side of the arch. Others may scan all the way around. That's your call. We just need to make sure that we get enough of the bite scan to orient, to align, if you will, the STL files in the software. Sometimes some of you may have some older iOS scanning units, and what we're finding is that when we're asking for larger data, when you're making these larger scans, that the systems keep deleting it when you hit to submit or to process. And what we found is that, and those when you're having those problems, you might need to set your scanner to denture mode, or some people found it's beneficial just to turn off the AI feature because AI is thinking, oh, you only thinking more crown and bridge. You don't need the anatomy of the alveolar ridge, the tissue beyond the teeth going 5, 6, 7 millimeters, and so it will cut that. And so if you're having those problems, two things is to check, try denture mode, try turning off your AI feature. Then for our fourth scan, this is a really critical one. So you're going to remove the provisional now, and you're going to be sure and clean, if it's necessary, clean off, any of the residual in the tissue. Hopefully, the patient did a nice job with their home care. If not, get on them about that because they've got to take ownership of this. Once they leave, and come back 2 years, 3 years later, if they don't come back for their routine appointments and they have issues, um, you know, they have to have responsibility here. So they got to be committed to their long-term home care as well. So you want to make sure that everything is clean and free of any debris. And so now you're going to scan the tops of the MUAs, and you're going to capture the tissue as much of the alveolar ridge as possible. Go back posteriorly, buccally, lingually, palatally. You don't have to catch the whole palate, but do capture again, at least always think about 5 millimeters below the transition line is a minimum you should be capturing. Okay. Just make that your kind of a rule of thumb and you should be in great shape. More is better if you can, but really a minimum of 5 millimeters is really the ideal. Now, the fifth scan, this may be where a laboratory might say, well, we don't need this. And the fifth scan is out of the mouth, is to scan a 360 scan of the provisional that they've been wearing. You capture the integular side out on the buccal. So some labs request it, some don't. Again, this is where you want to talk to your lab ahead of time about what scans do you need. Um, and hopefully you're welcome, if you're taking any pictures of these screenshots, you're welcome to do that on these steps. This will be posted on available. I think there'll be a link be sent out once we get it set up where it could be on YouTube. You'll be able to view it again there. But either way, just talk with your laboratory ahead of time so that you're not surprised on the day of or just the day before. Then the last scan that is required is going to be utilizing these a scan utilizing some precision scan body system. We work a lot with the systems you see here, the truss system, OptiSplint, the direct scan from Implant Direct. There's other ones out there. These are so we encourage you to talk to your lab again. What are they like? What are they working with? What works for them? Talk to your colleagues if this is new for you. Um, but these are ones that and I'm going to kind of walk through a couple of these just a little bit to kind of get you an idea of what that looks like utilizing the digital workflow. So for an example, I'm going to kind of give you a side by side or a top and bottom comparison of the truss system on the top going left to right and then OptiSplint. They're very kind of similar what you're doing. The design, the geometry is a little different. For example, Truss calls them a scan jigs, whereas OptiSplint from Dental Arches, that's called scan bodies. So, but you see here what you're placing these the scan bodies or the scan jigs, and then they're being positioned a certain way. OptiSplint has a framework that you would lute to the bodies themselves. Here you see up in the top that Truss is using some light cure material to lute the scan jigs together. Uh, then after you've done those steps, then as you see here on the top of Truss, once you remove it, you want to reinforce the connectors. In their protocol, you're going to add some analogs to the um, underside of the scan jigs. The They actually have a system where it comes with a little denture box and a pre-measured stone, and you can pour a master cast. OptiSplint, you're going to see here. So, again, you're going to reinforce that once you take it out of the mouth. Then they have a little device called a scanning plate that you can scan that and then send that to the lab. You don't need to physically send a jig into the laboratory. You can if you'd like. Again, talk with the laboratory. Someone prefer to do that. Then they can take that and pour a master cast. So a lot of things that can be done, different options. And again, I'm not here to dictate to what your laboratory should do or shouldn't do. I'm just sharing you a protocol that works. It's a proven system that we've been working, how we work, and just to give you a starting point. So once you have all those scans now, then you're going to upload those photos and the scans to the laboratory. And then, it's pretty straightforward. Once the laboratories gets all that, then you also need to complete, we have an online prescription for that. You want to complete that, make any notes about any changes that you're looking for. Um, Again, we need to know what is the definitive prosthesis going to be made of? Are you going with zirconia? You do nanoceramic? You doing a hybrid with denture teeth and acrylic and a titanium bar? And I'm going to cover those at the end of the presentation to give you an idea of um, kind of the advantages and disadvantages of the different final prosthetic options for you. So give you a prescription, then send to the laboratory. If you do have anything that you're sending physically to the lab, just make sure you package everything really well. If you've glued those jigs together and you're sending that in. If you're some of them, there's screws that are involved in these scan bodies and things. Again, just make sure you're keeping everything together when you're shipping things to the laboratory. Okay, so now we're actually going to, now we've sent that data in the laboratory, whether it's, the lab might, whether it's, 2 weeks, 3 weeks, I'm not sure what your laboratory turnaround time frame is going to be to fabricate the resin prototype. Again, that's why you talk to your laboratory. So let's look at, so now we're at our second restorative appointment, which is going to be trying in the resin prototype. So first thing we're going to do, obviously, is we're going to remove the patient's existing screw retained provisional, clean everything up, then seat the resin prototype prosthesis. And we like to suggest that you do the one screw verification technique, which is referred to as a Sheffield test. If you're not familiar with the Sheffield test, go to YouTube, just type that in or Google it. It's a really great way to make sure that you have a passive fit of a restoration of the prosthesis. These are for screw retain, not for any crown bridge cement retain restorations. So this is a good way to identify that if everything's fitting properly. So you put one screw in, seat the bridge, and then you add the screws, the remaining screws, place remaining screws. And now that everything's stable in the mouth, then do your normal evaluation. Check for the, is the patient happy with the aesthetics of it? Now, when we talk about the aesthetics of it, these resin prototypes, as you see in the image here, they're not real pretty. All right. They're probably not as nice looking. They could be. You see, I just had pop up on the bottom right the laboratory. If you're on these prototypes, typically they don't stain the gingival. Um, some labs may make it automatically, they do that. Some labs you may request that. There may be an additional fee for that because there is more time involved in doing that. But this is really verifying the bite. If there was a speech issue, if there was an adaptation of the, or integrity, if you will, of the fit between the apposition of the prosthesis to the crest of the ridge. Did we get that right? Was it captured properly in your scan? Does that feel better to the patient? Do we have any hissing underneath the prosthesis, et cetera? So what you see in the larger photo, the top photo there, is how they usually come just all pretty much white. But again, it is available upon request for them to stain that. So then with the prosthesis in place, we're going to want you to take photos of that. It's optional if it's minor changes. If you're having more, what I would call a major change, um, whatever you might determine as major, please take the photos. Again, the more the lab gets, digital is nice, but seeing a photo, it just gives them another reference point. Help us help you, in other words, is really what we're looking for here. So take those photos, scan the bite with the provisional in place. Now, if you made any adjustments to the occlusal surfaces of the provisional of the resin prototype, or the opposing, maybe you decide to make an adjustment on the opposing dentition as opposed to the prototype, you'll need to scan the occlusal of that of those adjustments so that the lab captures that and they have a new reference of the anatomy for being able to obtain the bite that you're looking for here. So again, noting the changes on the prescription, um, and submit your information. Now, let's talk about what happens if you have a case where, say, the tissue adaptation of the provisional is not acceptable. There was maybe more significant, there's always going to be some bone remodeling. Tissue follows bone. So when the bone remodels, tissue is going to follow that. And maybe there's some more gaps that are not patient's not happy with it, you're not happy with it. So to to address that, what you're going to do with that resin prototype seated, you're going to scan again that 5 millimeters beyond the transition line and then remove that. You don't need to scan the integral of that provisional because we have that already we have an STL file of that already from when we made that provisional. So we have that. Now, unless you're working with a different lab for the final, then you're going to need to do a 360 scan of that provisional. So something to keep in mind if you're changing the lab from what was done at the time of surgery to the final. So just something to think about as well. So what you're going to want to do is, so you have scanned the transitional line, remove the resin prototype. Then you're going to scan the top of the MUAs, again, capturing as much tissue as possible. Then you can reseat the provisional, or let's say that maybe you did quite a bit of changing in this prototype. The patient can wear this for 1 to 2 weeks, longer if need be. Usually 1 to 2 weeks gives everyone enough time to make sure that they're happy with it. That would probably be a scenario that you probably would want to have the laboratory go ahead and stain that gingival if you know you're going to do that. Um, but this way, the patient can say if you had a concern about the aesthetics, patient, the length of the teeth, they were catching their lip, they were lisping, something like that. The overjet, they were biting their cheeks, so that's been changed. So they can wear this prototype and then come back and say, yeah, that's great. Now, let's say that if they were happy with this try-in, they did the test drive, um, and they wore it, or you're just happy with it at this point, no adjustments were needed, or something was very minor. Then what you can do, um, you can just return that resin prototype to the lab. May not even need to physically return it to the laboratory, but you can just send the scans in to the laboratory. And if it doesn't need much of anything, you just reach out to the lab, whether you're calling them, emailing them, again, work out your communication protocol with your laboratory and go to the final. And so your third appointment, your final appointment would be just to finish it up. Now, if this happened at your earlier stage on your first restorative appointment, as I mentioned before, if everyone was happy with everything, yeah, it's your call, doctor. If you don't want to do this resin prototype try-in, that's fine. It's your call. Then you could just tell the lab, hey, everything looks good, pull the trigger on it, and they'll shoot you the final. So again, always if there's any screws that the lab sent, be sure to keep track of all those because if you lose them, you can be charged for more screws for that. So I think this covers, here you see again in step number 9, sending to the laboratory. So yay, that was our final steps for the resin prototype try-in. So what we're looking at now then is we're ready to deliver the final prosthesis. So this is your third appointment, maybe it's your second appointment. So this is pretty straightforward. You're just going to remove the provisional, clean everything up, seat the final, the definitive prosthesis. And then again, the Sheffield test is a great thing to utilize. And very importantly, now if you need to make occlusal adjustments, fine tune it, sure, go ahead and do that. But always I strongly recommend this. It's very beneficial to do this, is to schedule time with your patient after this delivery appointment with the hygienist. Because the reason that is that many of these cases, now that we've really readapted this final prosthesis to the tissues, that the way they used to do their home care might be a little different. Using a floss threader may not work the same way. They may need to modify that. for people that maybe have arthritic issues, poor vision, it may be something you have to work out with them because again, home care is critical for the long term of these, and the patients need to be committed to that. But don't just because they did a great job on their provisional doing it to think that they're going to know how to address and take care of this definitive prosthesis because again, it is going to fit differently. So there may need to be something done differently for that. So allow time for that. And the hygienists I talk to, they love it too because a lot of times they don't get to see the patient until months later to see what it looks like with their new smile. Okay, so be sure and do that. That's really a good thing to do. All right, so now what I'm going to do is I'm going to talk about the different options that we have for your definitive prosthesis. And there's probably a few other ones out there. I'm covering more of the FP3. I'm not getting into the FP1 fixed prosthetic. If you know you're familiar with Dr. Carl Misch's classifications. So we're pretty much this presentation and what I'm going to share moving forward here is referring to the FP3. So I'm going to talk about the key considerations and the benefits and potential drawbacks of these different options for you. Okay, so we're getting in our home stretch here. We'll do Q&A after we cover going through some of these. So before I get into the actual restorations themselves, I wanted to catch a couple of topics. I got a couple of slides here I want to address with you that it seems like this is causes confusion and actually can be a real problem in some situations if it's not thought about or addressed prior to where we're at right now with getting into the final prosthesis. And that is the inner arch space. So what I'm sharing with you, these next couple of slides, you need to be thinking about this before surgery. Okay, this is in your because my point is that when we going to go to a final prosthesis, you may think, I'm going to want to do a screw retained denture teeth and acrylic titanium bar hybrid prosthesis. It's the least expensive of most of them that are out there. They're options that you have. And so maybe you want to go that way. Well, you're going to find out that you need more inner arch space for that versus, say, a zirconia. And if you haven't planned for that during the provisional by opening the vertical, many of these patients, you need to open their vertical before surgery. You should anyways, because a lot of these patients have a closed or collapsed vertical. And I'm going to cover some more information about this. The numbers kind of vary how much inner arch space, but what I want to talk about right here is where are you measuring that inner arch space? Because some people will say, well, I measure from the platform of the implant to the occlusal plane. That's my restorative or my inner arch space. Others may say, oh, I go from the top of the multi-unit abutment to the occlusal plane. And that could be the lab mentality doing that or the doctor's mentality. But the point is, you have to have that conversation with the laboratory. Make sure you're on the same page about this because it could be a difference of several millimeters. And it can cause a difference. It may be that, doc, sorry, we can't do that hybrid denture teeth and acrylic. We need to go with the zirconia. Oh, by the way, doctor, zirconia is going to cost you, $1,500 more, $2,000 more. I don't know. But, you can't say you can't go to the patient and say, yeah, well, I know I told you this fee. Now we need this much. I think you get more on what I'm saying here. You don't want surprises. And you can really help to eliminate surprises. I don't know if you ever can do that, but you can really help to minimize variables, minimize surprises with communication, great level of communication. So make sure that you as a clinician, working with your laboratory, and for my laboratory friends that are listening out there, howdy hi, but have those conversations with your clinician. Make sure that you are all on the same page about what you're talking about. And then based upon the restorative material, the type of prosthesis, you may need more inner arch space, which is what I was kind of alluding to. And again, this can be quite a bit, it can be several millimeters difference, especially when you get into a double arch. That can really add up to be quite a bit. And when you get into talking about these doctors, that when the lab tells you how much restorative space you have your established VDO, your functional vertical dimension of occlusion, And that's where the patient's going to be when they, in their centric position or centric occlusion. Um, if the laboratory in your preliminary workup says, well, we need to have uh, this much restorative space. Well, you're either going to get that two ways to get that is either you open the vertical. If they don't have the space, you either open the vertical and reduce bone, alveolar bone. And I can tell you just from doing, our laboratory's done thousands of these cases. I've personally been in, hundreds of these cases, um, that the a person that has terminal dentition and is going into an all-on X, on the average, there's an average of 3 to 5 millimeters alveolar that needs to be done to get to this ballpark restorative space. So there's almost always some bone alveolar that needs to be done. Patients as edentulous, maybe there doesn't need to be any, maybe just enough to maybe flatten the bone off or to create a more conducive uh, anatomy to the alveolar ridge so you don't have, dips and valleys, so food can be trapped and hard for the patient to maintain that. Um, but it could be your choice, doctor, to say, well, I'm not comfortable removing that much alveolar bone. uh, if you're telling me, I can't open the vertical, if I feel I can't open the vertical any more than what I've done, and laboratory, you're telling me based on the scans, the CT, and all these other things, the criteria that's out there, if you're telling me that I need this much bone reduction, 7 millimeters of alveolar reduction or 5 millimeters, I don't want to do that. Well, that's great. It's your call, doctor, but that needs to be happening before implant, before the surgery. That's all done in your go-to meetings and discussions about that. So a lot of communication going in ahead of time to make sure that at this stage of the game, there's not any surprises. If there is a surprise, it's very minimal, and hopefully it's a good surprise. All right. So the other thing then to consider, and again, not limited to, is opposing dentition. When you're making a decision, what is going to be your definitive prosthesis? Again, what material you're going to utilize? What's the is there natural dentition on the opposing? Because if you do with a zirconia and maybe they have some other crown and bridge work, some of the old feldspathic porcelain, you might say, gosh, that's going to be pretty abrasive. They've got a lot of money into that. Maybe that's not the best way to go with zirconia. Maybe it's crown and bridge fixed. Again, maybe it's crown and bridge work. So again, knowing what is opposing, considering taking that consideration will help you make a decision toward the final. And your laboratories that are educated in doing these things can help you with that. What else? Now, then also evaluate the physiological and biomechanical conditions. In other words, how many implants are going to be placed? Are you only doing 4 or are you doing 6? Are you going to be able to get a decent anterior posterior spread, the AP spread? What's the musculature like? Do they have masseters that look like they could eat nails? Um, is there any parafunction? These type of things all would play into it. And I emphasize here about cantilevers because keep in mind, cantilevers in implant dentistry are nothing more than, they're magnifiers of force. And so that may make a difference also in what material is going to be utilized. And also, if you're going to have cantilevers, it might mean that if your initial plan was you're thinking for, again, these are things you need to be talking about pre-surgically. I'm sharing this with you now because because we're talking about final restorations, but there's I wanted to bring this up to you now because this is important considerations for you to be thinking about pre-surgically, okay? So keep that in mind. Again, parafunctional habits, you evaluate those. Zirconia prosthesis, there's no give. There's no periodontal ligament here. Patients have sometimes very limited proprioception. They may not really realize how hard they're biting. So things to evaluate with that. So then again, just the patient's expectation from a financial commitment, because there can be a significant price difference to the patient from what I'm going to show you in the next couple of slides of the different restoration options, and also their home care. How well are they going to be able to do their home care will make a little difference. And I'll talk about that more on each one of these restorations as I bring them up. Okay, so let's get into that right now. So we're going to talk about these are four of the restorations that we're, primarily seeing fabricated in the laboratory when we're doing this full arch all on X. And it's going to be your hybrid denture teeth with acrylic and a titanium bar, zirconia, the nano ceramic, and then what we're referring to as a titanium thimble bar with individual zirconia crowns. So I'm going to cover each one of these into that, advantages or into, kind of advantages, disadvantages, drawbacks, etc. So let's start first with the what I would refer to as like your conventional screw retain hybrid that we've been doing for years and years. Um, and so key considerations. Uh, Again, your occlusion, your vertical. A lot of it really here is about the vertical dimension of occlusion. We need room for these. This could be another thing to look at the posing dentition. If they do have crown and bridge work, or maybe it's a denture, it's a partial, maybe having something more of a like material or a material that if something's going to wear, look, these teeth are replaceable. So if something's going to give, the patient maybe does have a fair amount of bruxism issues, and if you'd rather have the teeth where that can be replaced versus, having the bone being lose bone because of the parafunction stressing out too many micro strains onto the implant bone interface, the bone dishisses. So, the material can make a difference here, and that could play a role in what would be the best for the patient. One of the, so the benefits, really, it is the least expensive of the options, less abrasive to your posings, and again, repairable. Um, but that's good news, bad news, repairable. I mean, there's cases of these because they are denture teeth. Now, a lot of times what we're seeing, what people are doing now is they're printing, so it's monolithic. So a lot of labs are not using, denture teeth processed in, packing it or injecting and using more of a methyl methacrylate and denture teeth. They're using printed dentures, so it's monolithic. So that's been a real nice thing too, is to have a monolithic situation here that fits over the bar, uh, as opposed to individual denture teeth. Individual denture teeth, they still have a propensity of fracturing off, and it can happen a week after the patient leaves. Um, it depends on, if you compromise that inner arch space and there's not much tooth structure, not much pink material to hold that, to bond that, it could be a bit of an issue. So something to think about. Drawbacks, I've just mentioned about some possibly teeth fracturing, staining glazing, I'm sorry, staining, buildup, plaque buildup. It does require more inner arch space, and the teeth do wear. But once again, that could be a good thing. But it's not a good thing if you don't let the patient know that. 5, 6 years down the road, they've lost some of their anatomy, they've worn that down, and their mastication is compromised because it's like just flat surfaces, trying to chew food as opposed to having cusp-fossa relationships. So again, it's not a bad thing, but communicate that to the patient so they understand. And I'd also recommend you note that in the patient's chart that you had that conversation because patients, not that they have, selective memory, wink, wink, maybe they do, but they do forget things. This is technical information that may be over their head. Okay, zirconia. So we're seeing a lot of zirconia. Probably 40% of the finals, if not more, that we're doing are the zirconia. Things to consider is what's the opposing dentition. So we do know that if you do zirconia, opposing zirconia, full arch like this, that it can be very noisy, like almost like taking two coffee mugs. And that's been a real issue for some patients. Um, Implant, again, number of implants, AP spread, your cantilevers, very rigid material. Night guards really should wear, whether it's a soft night guard at night to, prevent this, against posing natural dentition or other dentition. Strongly recommend that. I think the benefits here really aesthetics. And wow, today we've got some beautiful monolithic, meaning it's not layered, it's multi-layered, but it's monolithic. It's all one piece. Um, we're not doing cutbacks and then putting feldspathic porcelain to get more translucency on that. So we have these multi-layered pucks now. We're probably in our seventh or eighth generation of zirconia pucks for these full arch cases, and they really look beautiful. I think hygiene's a big one here because you're staining, that pink is stained just like glaze on a crown. So for a patient who maybe has had issues with uh, not the best home care, or plaque buildup, this is much easier for them to clean. Less plaque has less. Uh, it's doesn't adhere to it like it does to a the other materials and the nano ceramic coming up next as well. Again, the drawbacks. If there is any remodeling of the bone, tissue changing, you can't add to this. You can't send it back to the lab, have them add porcelain to it. That doesn't work. So you'd have to have a whole new prosthesis made if you needed to have a reline. Again, the clacking, the sound, and I tell you, it's more than twice as heavy as what you're going to see next, the nano ceramic. Uh, is that significant? Maybe on the lower for a small petite person, elderly person, and it's a large. They're pretty heavy. Not saying you wouldn't do zirconia because of that. I'm just bringing that up to you, something to think about. And again, wearing the opposing. Um, the nano ceramic, talk about this a little bit because some people they're hearing a lot about it, and it's something that they're interested in, but they really don't understand that much about it. So what it is it's a couple of components. So nano ceramic is going to have an understructure, and most labs are getting the material from the same manufacturer. Brand name, Trilor is a brand name here. Uh, Again, we're just, there's other products possibly that out there that might be utilized, but they're going to make an understructure, and then they're going to scan that understructure, and then the actual crystal ultra or the nano ceramic material then would be milled. And this is actually sitting on the occlusal on the teeth. So you're looking at the kind of from the integulo side of it. That then the laboratory will seat that over this framework and they bond it with special materials, bond it. You don't have to do any of that. They'll bond that. And then this pink is actually a lab light cured resin material. If any of you have worked with Gradia, another material, uh, some materials like that, but it's not like your light cure with a wand. This is a lab light cure unit that you would utilize to cure that. So then the lab would do a stain and glaze of that. Um, so again, this is going to be kinder to a natural dentition. So parafunctional habits, this might be something there that could be beneficial as far as wearing and opposing. Stress distribution, it's not as rigid as the zirconia. What we've heard, don't have studies to back this up, but when I took my training on this a few years ago with the people that the manufacturers, their engineers, they talk about this Trilor material having the consistency. Sometimes they talk about modulasticity, something like maybe like a D1 bone. So might be just a little, you can't put it in your hand and feel it, but functionally, when we're talking about all these microns of accuracy between photogrammetry and what we're getting with our iOS, especially our newer systems, um, sometimes having just a little give can be beneficial. Um, Big thing about this really is repairable. If they chip a tooth, you can just use your flowable composites and repair that. So that's a nice benefit to this material. A drawback would be that the glaze they put on is a light cure glaze, and over time that needs to be redone. Is that 6 months, 1 year, 2 years? A lot depends on, the patients, are they a coffee drinker, are they a smoker, wine drinker? Do they brush their prosthesis 3 times a day? Stiff brush, soft, hard brush, what kind of, adhesive, toothpaste, is it, abrasive? So it changed, but just know that that nice glaze you get is going to need to be changed. And now you can do this if you get very many of these going. I would suggest you buy one of these light cure units, and just do it yourself. It's very simple. You just paint it on, put it in the unit. I think it's about usually a 5-minute cure, And so you can do that yourself, don't have to send it off to lab and do that on a patient's home care recall appointment. And then the last thing we're going to have, then we're going to get into our Q&A. The last one is kind of the high-end one. It's going to be a titanium bar that where we create all the preps, and it's going to have 12 individual zirconia crowns. Emax crowns are available. That's going to be at a higher fee, but it'll be 12 individual crowns. It really looks beautiful. That pink on this is the same as on the nano ceramic. That's hand done by the laboratory. So you're going to have some of the same issues there. The laboratory will be cementing these crowns on. You don't have to do that, but they'll mask it out as you see in this bottom image here. The metal will be masked out, opaqued out, I should say. But again, if something fractured, it might be just a one-tooth fracture. It's not the whole prosthesis that needs to be replaced. So it'd just be a matter of removing that broken crown, scan it like it was just a broken implant single unit crown. The lab has it on file. You don't have to worry about proximal contacts. Nothing's changed. And then they could, they could mill you a new crown, send it to you, and you just replace that one crown. And I really want to say thank you so much for your time this evening and for your interest.